To today's report out. We've got Less Time, Move More, the National Cancer Patient Experience Survey, and then digital photography. Usual format, we'll hear from our three colleagues and we'll save up our questions till the end. So without more ado, can I come to Rebecca?
Hi everyone. Hello, my name is Rebecca McManus. My pronouns are she and her, and I am currently working in the health and wellbeing team on moving and handling training. So my LIM improvement method is called Less Time, More Move. And if we go on to the next slide, I will talk you through the problem and the challenge we have in the trust, or had. So moving and handling historically for many, many years, I've been in the trust 13 years, and it's always been the same. It's been a 4-day course, 9 while 5. And this course was an amazing course. I did it myself. Staff enjoyed it. However, getting a member of staff out of their primary role, because everybody is a moving and handling key trainer as part of their day-to-day tasks, to pull somebody away for that amount of time, you're removing people from patient care. People were really struggling to manage this need. So much so that our key trainers dropped to about 50 key trainers within the organisation, many of which did not feel comfortable. Throughout COVID, we didn't have a lot of face-to-face training, if any. So out of those 50, we only really had a small handful of people that still felt able to commit to being a key trainer and updating people in the organisation. So if we go on to the next slide, please. So I came into the moving and handling role, and what I wanted to do is I wanted to look and see how we could make some improvements. So I attended the Leeds Improvement Method training, and some of the tools I looked to use as part of that training, specifically for me and my project, was the Tim Wood 7 wastes. For example, I found overproduction of content. Now, the content was long and like I said, it was wonderful. However, a lot of it was unnecessary. That people were learning moving and handling techniques that they were never going to use, and it really wasn't productive. So in addition to that, I found over-processing of how we then recorded that training. So your key trainer would do all this training, they would go out and train people, they would then have to go and make time to upload onto ESR, which is very time consuming. People were having to wait for their training to be updated. So that's some of the areas that I looked at. What could we potentially reduce? I also looked at the inventory that we had, and we had more than enough equipment, too much equipment. That equipment needs to be stored. That equipment needs to be serviced. It needs to be looked after. So I looked at what could we take away that we didn't actually need. And the defects as part of that 7 wastes, what I found was everybody did the same training. Now, whether you're working in estates and facilities and being a moving and handling key trainer, or if you're a registered nurse and being a moving and handling key trainer, you had the same training. Yet both roles were very different, and both people were training very different needs in the organisation. So why we're giving them the same training, I didn't think that was effective. So we were looking at making it more person-centred, which is in line with our Leeds Way values. Patient-centred, but for me, very much staff focused, so staff-centred training. So another tool that I used was the stakeholder analysis. So I identified who I needed to collaborate with, and from this I held focus groups. And in those focus groups, I listened to people, and I wanted to find out what people wanted as well as what they needed, but all the while remaining and maintaining that level of training that we needed to meet legal requirements, and also to fit in with our trust values in being the best place to work and the best place for patient care. And what I managed to find was we could remove a lot of the training, a lot of the inventory, and we could also remove and change the way we uploaded that training onto the training interface. And what I managed to do, if we go on to the next slide, is I managed to take that training from 4 days, 9 till 5, down to 2 days, 9 while free. So I've dramatically reduced that time. And because of this, we got lots of people wanting to send people on the key trainer training, so much so that our instant wins within between 6 and 12 months, we went from 50 key trainers in the trust, of which only a small handful were actually doing the role, up to 251 that we currently have at present. Now, all these 251 key trainers are out there and meeting the needs of our staff, and we're supporting our organisation to be updated in line with legal requirements for moving and handling. And in turn, that supports better patient care as well. Now, what that was a quick win. The longer term win is people getting on board with finding out who their local key trainer is. Because it dropped off for quite a while, we're working now with the comms team to get communication out so that people understand, in order to have their training updated, what their next steps needs to be. So while we've got the quick wins of lots of key trainers throughout the organisation, and I've still got training booked out for the next 3 months ahead, and more people on my waiting list. So there's still a need for this, and there's still a great interest in it. What we need to catch up with is getting everybody actually through that training and really making the use of their key trainers. If we go on to the next slide, please. What went really well is CSUs have been so engaging in this. The minute we kind of had those focus groups and looked at reducing the time of key trainers, everybody wanted a part of this. And we've also had central training, but where possible, I've gone out to peripheral sites. So like Wharfdale that struggle sometimes to attend training at, say, St James's or the LGI. I've managed to work with them to do some bespoke key trainer training. They've provided enough staff. I've gone over and used their equipment and really done more of a closed session meeting their needs. So we're able to get out and about and provide training for more areas of the organisation that may otherwise sometimes struggle. Feedback has been really well received. We've had lots of praise of the less time, more move. And actually, the less you give people, sometimes the more they take away. So we've taken away that overload of information. So people feel like what they have taken away is really, really valuable. It really has worked well. Next slide, please. In terms of what I would do differently, we do have next steps of how we can make improvements. So the importance of evaluating our existing practices and the effectiveness of focused lesson delivery, in other words, so we maximize the knowledge absorption that people take rather than them taking away lots of interesting bits of information that they're never actually going to use. That's where we focused our tools to work with. And going forwards, we're looking at how people, once they've got the basics, if they want to increase their knowledge in a particular area, how can we meet their needs? So we do have next steps on how we can make this even more improved while still meeting the need of that less time, more move. And that's it from me. Thank you.
Fantastic. Thanks, Rebecca. Really great. Well done. Really good presentation and really high impact from your project. So again, well done with that. Well, as I said, we'll hold questions. I'm sure folk have got things to ask around a really important area of training, but we'll go on to, I can see Karen on the call. So let's come to you, Karen.
Thanks, Phil. My name's Karen Henry. I'm the lead cancer nurse for the Trust. And my improvement project was around looking at the scores we received from our National Cancer Patient Experience Survey, and particularly those from our BAME group of patients in relation to their experience of getting a diagnosis of cancer. Can I have the next slide, please? So this did feel slightly out with normal things that you would use LIM methodology for. It's not a numbers problem, but it was the thing that I was dealing with when I was doing the course, so it felt appropriate to bring it. So when we analysed the results from our Cancer Patient Experience Survey, the last lot of data we got, which we got last year but was from 23, we really did have some much lower scores for some of our Black patients and also our mixed patients in relation to their experience, and that it wasn't nice to see that, and it's kind of the second year running that's happened. I think it particularly at the time linked to the reducing weights commitment, because I think if people don't understand what we're telling them and how important their diagnosis is, they're less likely to then comply with appointments and treatment that that follow on from that. But I think the new 7Cs, it really, really links to Compassion Does This, about moments that matter to our patients. And I'll talk a little bit more about that as I go along. Next slide, please. So what did we do? I put out an email, some communication to kind of all of our MDT lead clinicians and also our lead nurses and the clinical nurse specialists in the trust. And I had so much interest from people wanting to be a part of this work. I think it strikes to the heart of people. I used the Cotter 8 Steps for Change model because that seemed, it just fitted. It felt creating that sense of urgency and purpose to do something about this, and then getting the right people involved. And I also used the stakeholder analysis tool to make sure I was targeting the right people. So then I engaged those people in some discussions about what we could do, shared the data, presented some evidence, had some help from the patient experience team, and together we kind of built this sense of wanting to do something differently for this group of patients. Next slide, please. So the things that came up from the discussion was a real lack of clarity around how we're using interpreters, and particularly when we're giving diagnosis and talking to people about treatment, there was some confusion that face-to-face interpreters weren't a thing that you could use anymore. That there was some distress from the staff that actually using the robotic kind of interpretation was really difficult in these sensitive conversations. So on the back of that, I went away and I met with the lead for the interpreting service and got some really clear guidance around what we can and what we can't do. And I was able to share that with everybody, kind of that standard work of this is what we do around interpreters. We also talked about how difficult it is when you feel you can't say someone's name properly. And I think this is where it goes back to that moments that matter. If somebody comes out and calls your name and they don't get it right, or they're too embarrassed to then continue to use your name through that consultation, you don't build that connection with people. So I've put in a request to the PPM Plus team to be able to phonetically spell out people's names in PPM Plus, and that request, put in a request for change, that's been accepted. This will obviously go across the whole trust, not just for our cancer patients. So that's in a queue waiting to be built. So we haven't had time to put any metrics in place, but through our Cancer Health Inequalities group, we're looking at how we might develop some metrics around the interpreting action. And there's a potential there to look at some DNA data. And when we get our CPES data in for the following year, we'll be able to assess the impact of some of these changes that we've made. Next slide, please. So what went well? Really, really great engagement from key stakeholders. There was a lot of interest to look at this and to improve experience. Really grateful from the development team. I put that request for change in. The feedback I got was that the CCIOs on the group were really keen to support this, and I know how many requests to get, so that feels really positive. And a really simple, quick win in the form of just meeting with the interpreting service and getting out some really clear guidance to people about what we can and what we can't do. Next slide, please. What would I do differently? It was tricky from the amount of interest that I had. We had quite a small group because getting clinicians together is really tricky. And maybe in hindsight, what I should have done is had more than one group. Key learning, I think when I started the 3-day program and I brought this as a problem, I thought, I've no idea how we're going to do this, how we're going to make these changes. But actually, there's always a way. There's a small thing that you can do that just gets the ball rolling and gets people hooked, and then you start to see bigger change. Next steps is to wait for that PPM Plus development to be built, and then to think about the metrics we could use to test if it's created change. And this year we're looking at, through another piece of work we're doing, where we've been out to talk to some of our BAME groups in different community settings and groups, to do a bit more of that, to get people to talk to us about their experience of care, as well as what we get back in our national survey. Is there another slide? I think so. No, that's it. That's me. Thank you.
Fab. Thanks, Karen. Really great. I think that's a really important piece of improvement work, and as you say, really speaks to some of our patient experience and what's important to them. So I think really important, and some great lessons I think about starting small, and there's always something we can be trying to do to improve. So it's really good to hear. We'll go straight on to Keith. Hi Keith, I can see you on there. Digitising photography, thank you.
Yeah, so my name is Keith Smith. I'm a corporate cancer team project manager, and this was to do a placement within the skin team. Next slide, please. So this is the photograph and operative procedure booking form. So this is what we're digitizing. Next slide, please. Now, at the start of this project, there was major funding issues. It was kind of like, if it requires funding, the project will not go ahead. There was a massive issue with stakeholder engagement, as it's been attempted before and failed. We also needed multiple department approval with stakeholders, and the technology required to gain the patient signature. Again, we had to make sure that was in place. And my own personal knowledge, so this was within 6 months of me joining the trust. I had no experience within healthcare sector and how things operated. And we experienced issues with risk of losing patient information, and this is due to it being handled as a paper form. Next slide, please. These were the alignments within the 7 Cs. Now, timeless, obviously reduced obviously reduced waits for patients, resources, obviously use existing systems to their full potential. Team, I know that team is on here, but the reason why team is that we reached out to Manchester, we reached out to Newcastle and other trusts, and no one had a process in place. And some of them were in a worse place than where it is. And the clinical team physically said that if we're able to do this process and digitize it, they already know that staff will be engaged and it will keep staff within the service. And obviously finances, which is deliver this without any impacts on finance. Next slide, please. So my actions was to organize an observation with the medical photography team. And this was a timed observation. Again, this was the first time ever doing a timed observation. And we experienced issues with different patient wait times. And the average time for patients was anywhere between 18 minutes. And we also did some other findings, which was presenting back to the actual TRI team. Now, the findings for this was an issue with gel. And what this is when the gel is put on patients' markings, when the photo is taken, the gel smudges, so you don't get the exact precise point of where the clinical team mark for an excision for patients, which then led to me having to complete a DIT expression of interest form. Next slide, please. It ended up that the project was success, and we obviously it had been taken over by the PPM Plus team. Now, my finding here is the design will start somewhere within Q2 2025, and the gel is still being investigated. And the reason for that is in theatre spaces, the gel that they use doesn't seem to leak on the smudges for patients when the mark is on the patient, but the gel that's used with medical photography is still being spludged, and it's obviously causing issues. It has been passed to the business manager, who's still investigating the supplier to see what supplier they can fix and change for that, but it's still an ongoing issue. Next slide, please. What went well is I gained knowledge of trust process and procedures. I did raise a lot of morale within the team, and this was mainly because there was no engagement at all. It was a big project to take on as like my first project within the trust. It was kind of like no one believed in the project. And we also changed process for patients experienced with mobility issues. And this was from the Times observation. So patients with mobility was seen on ground floor for clinic, and the medical photography was taking place on clinic, room 2, which is floor 2. And what I noticed and fed back to the clinical team is that medical photography is to realistically go down to the actual clinic space where the patients are. As we are really being patient-centered, it would avoid issues, because sometimes patients would come up the lift and there was no wheelchairs available for some patients, which means that the time spaces between people being seen in clinic averaged, and these patients tend to be around about 25 minutes or so. Once live, we'll have the knowledge to be able to share with other trusts, and that's one thing that Manchester and Newcastle obviously reached out and said it'll be much appreciated, as they would obviously see the benefits in this as well. Next slide, please. Obviously, what I would do differently is I was moving at pace with the project. I had massive clinical engagement as well as engagement with the clinical team. And as I was still direct support for skin for that time, I should have taken the project on or asked to take the project on to continue the pace. As right now there's a slowdown, and obviously we're in a queue with PPM Plus team and nothing can be done about that. I learned that even when others see challenges in there, still have to overlook them. And if you know a way of doing things and in the digital space and how you can make processes and changes happen, you just have to go with your gut sometimes, even when others don't believe. And obviously the next steps is also to bring transformation to the melanoma team. And then next slide, please. And that's it, yeah.
Well done, Keith. Really good, really great piece of work, and well done for kind of embarking on that just a few months into the role as well. I think that's really fantastic. So well done you for having the courage to do that, and all the learning that brings. So well done. And well done to all three presenters, Rebecca, Karen and Keith, for absolutely being bang on time. So that's another good process delivery. So let's open it out for some questions and comments from colleagues, please. Who would like to start off? If I could just ask Rebecca, one of the challenges about sort of simplifying training, which can be very appealing, but it potentially then doesn't give us what we actually need. What's your sort of reflection on how we get that balance right between making sure people have actually got the skills they need versus making the training as simple as we possibly can?
Yeah, you're absolutely right. I mean, we did review the content of the training and only took out what wouldn't actually be used. For example, we have something what's called a spider hoist, and it hoists somebody off the floor completely laid flat. Nobody in the organisation really even has these attachments in which to do these moves. So having it in the training and then going out into your working environment and not being able to do the techniques. And for example, we have our falls rescue kit, which is separate now. So we really looked at what would be beneficial for different areas. And in addition to that, one of the things we've done now is what was part of our next steps, which we have just started to put in place, is offer CPD days throughout the year. So we will get different organisations in. So it might be me delivering that training, but it might be Arjo, for example, that provides some of our equipment, and people book on and have that extra training. So by the end of the year, the training could actually be more fulfilled because they can pick and choose what's relevant for their roles while still getting the basics of what everybody needs. So we did go through it kind of ensuring that people weren't leaving without what they needed. And we keep that consistent communication up. So if somebody feels like they're struggling, if somebody feels like they want more, we keep that communication up, and I can go out and do visits with people. So it's trying to cover all areas. But yeah, you're absolutely right, making sure people leave. And actually, because we've taken a lot out, what they do take with them, they remember a lot clearer. They're not as overloaded. So it seems to be working.
Good, thank you. I've got a couple of hands, folk wanted to come in. So Magnus?
Karen, fab work. My question to you is, where next? And can we apply this to our staff and colleagues as well?
Thank you. Where next is, I guess, want to see what the survey shows this year. One of the other things we're doing is we're revamping our information and support service, making it a more formal referral, and we're aligning it with the new health inequality strategy for the trust, so that those patients who we know have more trouble accessing support. So those from a BAME background, deprived area, an SMI, a learning disability, we're going to offer them a bit more hand-holding than we normally do, to make sure that we're bringing up that equity of care and equity of access, because it's quite alarming. One of our project workers, Becky, who's been doing the work on the information and support service, went out and talked to various communities, and what they fed back was that they don't fill in the surveys because they don't believe we're interested in what they've got to say. And that made really hard reading. And so I think we've got to find better ways of engaging with people who we know struggle to access our services, to hear it directly from them. So that's where next, I think, for me, is how do we do that in a meaningful way to influence service development. Sorry
to interrupt, but I'm seeing parallels with what's going on in maternity at the moment as well. And being able to, we call them hard to reach populations, seldom heard, and we don't really actively listen. So I just wondered if there's any way we extrapolate across multiple CSUs with this work as well. Yeah, definitely. I need to think about how I can link you in with others. Okay.
Great. Thank you. Katie?
Thanks. 3 really good projects there and presentations, and I just wanted to say it was really clear from all of them, and it was great to see it coming through all the stakeholder side of things. So everybody mentioned stakeholders, and in our little LIM triangle with the tools down one side, leadership and the culture, a lot of people focus on the tools, but actually you've all pulled out of that. The important bit is the people in the middle, the people that support your projects going forwards and needing that stakeholder engagement to help move it forward. So I thought it was just really good to see that coming through. And also, Keith, just to say that go-to part of the Leeds improvement method, going to go and see with your own eyes, is clearly what you've done, and that's really helped move that along for you as well. So well done for that. That was it. Thanks.
Yeah, thanks, Katie. And Keith, I was just going to ask about when, you know, the benefit for staff working there with this digitisation. How are you? Is it just how are you picking that up? How are you going to think about kind of capturing that?
So we've already got steps in place and drafts already done with the TRI team of what data would be important to try and pick up and sift out, and how we can utilize that for staff improvement and even training as well. So there's a lot of stuff that's on there, but again, that's more picked up by the service manager and that side of the CSU. But my input would just be like, if that's what they want to have, I will then go in and do the work to get that done for them. But we've already got discuss of that, and everyone's excited for it. And the general manager has been pushing along to the executive team to try and get this rolled out as soon as possible.
Yeah, fantastic, Keith. Never say you're just here to do something, because actually you're here to play a really important part in the team, and this project shows that. So well done to you for doing that, I think. So look, that we're just at time, and thank you to Rebecca, Karen and Keith for 3 really great pieces of work. Again, lots of thinking around how we can spread this around the organisation, because some of this it would really benefit other parts of the organisation other than where you've worked. So well done to all 3 of you. I'll bring a report out to a close, and thank again presenters, and thank you for coming and listening and the questions. Cheers. Thanks, everyone.
Thanks.